Hi, everyone. Welcome to our webinar. If you're having any sound issues, please let us know by typing a message. My name is Dave Lederer. I'm a pulmonologist in New York and a medical advisor for the foundation. And I'm joined here by Dr. Joyce Lee, who's a pulmonologist in Denver, Colorado. Welcome, Joyce. It looks like we lost Joyce, but she'll be back. We also should have Dr. Kevin Flaherty joining us in a moment. So today we have an Ask a Doc question and answer session. We've received quite a few questions from you folks as you registered, and we're going to go through them one by one during the conference. If you have a feel free to type in your question in the little text box that you see on your screen. So in the meantime, we'll go and get started. Joyce, are you there?
Yeah, I'm not, it keeps going in and out, so I'm not sure. Can you hear me?
Yeah, I hear you fine. That's great. Okay. So before we do start, I want to make one disclaimer, which is that we're not here giving you medical advice, and we're not making any medical recommendations. We're going to be very clear that we are providing you information that you can then talk to your healthcare provider about and see if our discussion is applicable to you. So please don't make any changes to your medical care based on what we say today. So we're going to start with the category of diagnosis. And a very common issue that comes up is the issue of lung biopsy. And the question we received was, I was told I need a biopsy of my lung before my doctor can give me a diagnosis, and I'm worried about complications. Do I need to have a biopsy? Joyce, do you want to maybe comment on that, and I'll fill in as well?
Sure. I think there are circumstances in which we can make diagnoses using non-surgical methods, but there are also other cases in which surgical lung biopsy can aid in the diagnosis of an interstitial lung disease. So I think it's obviously dependent on the particular circumstances around the patient.
Yeah, I completely agree, and I think that's the bottom line, is that for some patients, at least in my experience, a lung biopsy can give us very important information, not only about diagnosis, but in some cases, more importantly, how we're going to manage a patient, whether it's medication A, medication B, or avoiding medication entirely. But yeah, there is a risk of complications with any medical procedure. And some people may be at a higher risk than others. So again, it is important to talk about it with your doctor and the rest of your medical team. So and again, this is I think this comes up every day in my practice. So it's a very relevant question, and I'm glad one of you submitted it to us. Next question is about what we call familial ILD, and here ILD, of course, stands for interstitial lung disease. So how much of familial ILD is due to exposure to the same environment and to genetic pass-through? That's the question we received. Familial refers to, actually, I think we have Dr. Flaherty now. Kevin, have you joined us?
Yeah, can you hear me, Dave?
Yeah, we can hear you. You're a little bit quiet, but we can hear you. That's fantastic. So welcome, Kevin. Dr. Kevin Flaherty is a pulmonologist in Michigan at University of Michigan, Ann Arbor, and is the chair of the PFF Care Center Network and Registry. Thrilled to have you. And Kevin, Joyce is on the line as well.
Hi, Kevin.
Good afternoon.
So Kevin, maybe you want to address this question. I'll put you on the spot right away. Which is about familial ILD, or ILD that runs in families, for our listeners, and whether there's only a genetic component, or might there be some environmental exposure that could be causing disease in two family members?
Yeah, so my suspicion is that it's a combination of both, that there may be some genetic predisposition, but then there's environmental factors, such as cigarette smoking or other things that could injure the lung that would start things off or predisposed to the scarring process. I think it's both components.
Yeah, I totally agree with that, and I think that's not only true for when it runs in family, but of course that's true across the board with with all ILDs. We think there are multiple contributors to every individual's case. We do have a couple of questions that people have put in, and maybe we'll jump to those instead of going to the next slide right away. So one listener said, I have IPF and I'm working towards lung transplant. What are the pros and cons of a single and a double lung transplant? So I'm happy to address that. That's an excellent and, again, common question that we see in our office. So lung transplantation, for those of you who may not think about this all the time, lung transplantation is the replacement of either one or both lungs with lungs from a donor. Donor is, in almost all cases, a deceased donor, someone who is hospitalized and has passed away, rather than a living donor, which is very rarely performed for lung transplantation. And the question here specifically is about single versus double, meaning should someone get one lung replaced or transplanted, or should someone get two lungs replaced and transplanted? And it is a large topic. There's a lot of information about this, and probably more opinions among us physicians than data that we have. So I'll say a couple of things that, at least in my experience, and some data bears this out, that if you get one lung replaced or you get two lungs replaced, you still feel about the same, meaning that you'll come, in the vast majority of cases, you would come off of oxygen completely within a few days to weeks. You would not experience shortness of breath during your routine activities and routine exercise. I suppose if you tried to run a marathon with a single lung, you might run into problems, maybe. And a single lung transplant actually is in many cases an easier surgery to get through. And also on average, the waiting times for a single lung transplant are shorter. Having said all of that, there is some data that getting two lungs may help you live longer than getting one lung if you do have pulmonary fibrosis. But that, of course, has to be balanced against the downsides of a double lung, which is waiting longer. And if you have to wait longer for two lungs, some people wait too long, and their disease progresses before they're able to get a lung transplant. So there's two sides to that coin. And for an individual patient, there may be very good reasons to do a single lung transplant, or there may be very good reasons to do a double lung transplant. So it really can be tailored to the individual patient. And the information that we're giving you, again, very hard to apply to an individual person because we need to individualize that decision. And I'm sure that's what your transplant team is thinking about and eventually we'll be discussing with you. So we have another question in there as well, but we'll come back to it. Maybe we'll get to a couple more of the questions that we've posted up on these slides, and then we'll come back to Claire's question. So next question also falls under the diagnosis category, and is what kind of testing is currently available for children of those living with familial interstitial lung disease? So this would be someone who has a form of pulmonary fibrosis of some kind, and then there's in fact, if it's familial, that means there's more than one person in the family. And then what should be done for the children of people where there's two or more other folks in the family with pulmonary fibrosis. And I think in general, we're referring to adult children. We're not talking about teenagers or younger kids. So Joyce, maybe I could turn to you again about this topic. I mean, I know what your answer is going to be, but maybe you could share what your practice is maybe you could share what your practice is.
Sure. I mean, I think if you ask several of us, you're going to get a variety of different answers. But in my practice, I don't routinely test children for genetic mutations associated with interstitial lung disease, partly because we, like the other question highlighted, it's not just the genetic risk, but the environment that interacts with those genes that leads lead to the disease. So I think that we're not at a point yet where we can accurately predict who's going to get the disease based on a genetic test. So what I do counsel them on is generally, healthy lifestyle and smoking cessation if they're smokers, and early recognition of symptoms.
Yeah, I think that's certainly what I do as well in the clinical setting. Kevin, do you want to add anything to that?
No, I would just agree. It's really much more, I think at this point, counseling about healthy living and avoiding potential environmental insults as opposed to specific testing.
Yeah, yeah. Again, that's exactly what I do. And there are a number of centers around the country that are doing research in this area, studying adult children of folks with pulmonary fibrosis. And you can learn more about that if you reach out to our Patient Communication Center at PCC at pulmonaryfibrosis.org, or go on our website. We can always provide you with more information about that. So another question we received just now is, can pulmonary fibrosis be caused by sarcoid? I think I got knocked off there for a moment. Can pulmonary fibrosis be caused by sarcoid? Sarcoidosis is a fairly common disease that often has a very benign course. It's an inflammatory disease that can involve different parts of the body, including the lungs. Yes, pulmonary fibrosis, sarcoidosis can lead to scarring in the lungs, and which would be pulmonary fibrosis. But I will say many people who have sarcoidosis never develop pulmonary fibrosis. They can either have more inflammatory involvement of the lungs, or in some cases, no involvement of the lungs at all. And so if you or a loved one has sarcoidosis, it's certainly a good idea to talk to your doctor about whether or not you could have lung involvement. Or if you have pulmonary fibrosis, your doctor might be considering sarcoidosis as a possible cause of your disease. Let's move on to the next question on the slide, and thank you for that question. So this is also a question about diagnosis. It's my CAT scan report said I had traction bronchiectasis, that's a handful of a term, honeycombing, and interstitial changes. Now, what does that all mean? Is it all pulmonary fibrosis or something else? And Kevin, I'm sorry to put you on the spot there, but maybe,
okay.
And it's a lot there, but maybe you can unpackage those terms for us.
Yeah, I'll try, and you can try to help me along the way, Joyce and Dave, as well as we go through. But it's a very good question, and just trying to describe them. So if we take them one at a time, traction bronchiectasis refers to the airways in the lungs. And as scar tissue in the lung contracts and gets smaller, which is what scars often do, they can pull on the airways, and those airways then get bigger and more dilated. And that dilated airway is called bronchiectatic, and that's where the bronchiectasis comes from. And the traction just refers to the fact that the mechanism by which that airway is being dilated is because the scar tissue is pulling on there. So the traction bronchiectasis is more of a sequelae of the fibrosis and not fibrosis in and of itself. Honeycombing also is a manifestation of fibrosis. It looks like a bee's honeycomb, and it's often around the very edges of the lung. And we use that somewhat diagnostically, but it is basically just a description of one way that fibrosis can look. And I would say the same way with interstitial changes. All these things that we're describing are interstitial changes, kind of I think of it maybe as the meat of the lung, the things that are holding the lung together. Is more of the interstitium, and when there's thickening or changes there, those are interstitial changes. So that's my first stab. It's a very good question, and it's very hard to describe, particularly without being able to point at a CT scan and illustrate what those different terms might look like.
Yeah, thanks for that, Kevin. Joyce, you want to add anything?
No, I think that was great.
Yeah. I guess the only thing I would add is that none of these are specific diagnosis, and that's sometimes what I hear patients say to me. So I have honeycombing or I have traction bronchiectasis. So those are, as Kevin said, findings on a CAT scan, meaning we visually see them on there, and then your doctors will use that information in combination with all of the other features of your condition to reach a diagnosis, meaning some specific form of pulmonary fibrosis. So that was a really important question, something that comes up a lot. We'll move on to the next one, which is, I've read that after a person has been diagnosed with PF, the average life expectancy is then about 2 to 4 years. Is that accurate, and are the new treatments helping this? Joyce, I'm sorry to put this one on your lap, but I think it's, again, a common one, an important question, and I think something that we talk about very commonly with our patients.
Yeah, so I think it's important here to highlight accurate diagnosis when it comes to answering this question, and I think the condition of idiopathic pulmonary fibrosis, so a specific type of pulmonary fibrosis, we do think that the average life expectancy is anywhere from 3 to 5 years. So that is what we've learned through the years. And the therapies that have been approved recently, although haven't proven that they will extend life expectancy because we haven't had them around long enough, we expect that that people will live longer with the disease because it slows disease progression. This life expectancy estimate is not something that we can say about other conditions that are also associated with fibrosis. So I think this is really specific to that particular condition of IPF.
Right, right. Kevin, anything to add there?
No, it was just that even within specific diagnoses, it's just, I think it's important to realize that these are rough estimates, and unfortunately, some patients can have a more rapidly progressive course. So it's important to monitor things, very closely from the very beginning. But on the favorable side, there's also patients whose whatever the disease is much more indolent and can certainly survive with great quality of life much further than 2, 4, or 5 years. So I think it's really on us as trying to understand these diseases better to try to figure out what those differences are, so that we can both do a better job of predicting for individual patients what the future might look like, but also then trying to understand why those differences are there and how that might allow us to figure out what therapies could play a role.
Yeah, I think both are great perspectives. So thank you. Our next question, we're going to transition to symptoms and management. And I think something that, again, is common in our practice is exhaustion and what a physician might call fatigue. So this question is, I'm exhausted all the time. Is this common in PF? And does anything help? I'll say in my practice, many of my patients have fatigue. And I think sometimes it's a little bit hard to distinguish fatigue or tiredness, so to speak, from shortness of breath or breathlessness that occurs during exertion. But certainly if you're living each day with breathlessness and trying to be active, that certainly can all by itself wear you out and be exhausting. It is common, but certainly also important to talk to your doctor about any other causes of fatigue that might be present. We want to automatically ascribe it to just to your lung disease. So Joyce and Kevin, is this common in your practice? Do your patients report fatigue to you?
Yeah.
It is, and I think your point of really looking outside of the lungs, outside of the fibrosis, to make sure there's not other reasons that could be addressed to help with that, and that may be things just like even a low blood count, or your thyroid level being low. There's lots of other things that can cause people to feel tired and fatigued. Dave, I don't know if you want to comment some on sleep apnea and kind of what that is and how common it seems to be in IPF, because certainly, untreated sleep apnea can also be a common source of fatigue in many of these patients.
Yeah, that's exactly right. And sleep apnea, particularly in people with idiopathic pulmonary fibrosis, seems to be very common. That's been looked at a few times. And certainly sleep apnea can lead to sleepiness during the day. So if you're someone who falls asleep frequently when you're not engaged in activities, feeling sleepy, unrefreshed in the morning, as if you didn't sleep well, certainly if you snore, these would be reasons to talk to your doctor about your own health and see if sleep apnea might be a problem for you. And in general, sleep apnea is simply common in the whole population of adults, not just in people with pulmonary fibrosis. Joyce, anything to add your experience with fatigue in your practice?
Yeah, I 100% agree. I think it's actually very common, and looking for reasons besides the lungs that might be contributing to fatigue, I think is incredibly important, including the mental health of our patients. Depression and things like that can certainly lead to symptoms of fatigue, and would make sure that the fatigue is not due to something else.
Yeah, I agree. I'm glad we reinforced that. Wouldn't want to miss anything. So our next question is, I have a pulmonologist who sees me every 6 months. Is there something else I should be doing? Should I get a second opinion? I could address that, and I guess the answer is that it's very hard, or maybe even impossible, to make any statement about the right way or the wrong way to take care of an individual patient, particularly with regard to follow-up, unless I were that patient's doctor, and I could help in that case, make a recommendation about how often someone should be followed. And certainly there are patients where it's appropriate to follow them every 6 months, and there are other patients where it's appropriate to follow more frequently. So that addresses the first sentence. The second sentence, I would maybe even think about that as a completely different question even. Is there something else I should be doing? Well, I would say, independent of how often you see your doctor, if I could just take an aside and move away from the question itself, there's so many things that I think everyone with pulmonary fibrosis should talk to their doctor about, and whether or not they're right for them, including an exercise program like pulmonary rehabilitation, getting influenza vaccination, getting pneumonia vaccination, getting referred for lung transplantation, getting engaged with the pulmonary fibrosis community, which you can do with the PFF, and always, as I mentioned earlier, you can always reach out to the foundation through our patient communication center at PCC at pulmonaryfibrosis.org, or call us at 1-800-TALK-PFF. You can find all of this information on our website, which is pulmonaryfibrosis.org. And there's a lot more, and you can look at our patient education booklet, which is also available online or through our PCC. To get a lot more information about, quote unquote, what else should I be doing? And then regarding second opinion, that's an individual decision, and I don't think it's ever wrong. I have patients of mine who go and get second and third opinions, and I think that's fantastic. I love having other people's input. Kevin, do you want to mention the Care Center Network? Kevin, did we lose you? Oh, there you go.
But no, I was on mute for a second, so I apologize. I just would second that your thought that, I just with my patients as well, I'm always try to facilitate, if they'd like to get a second or third opinion, to have somebody else thinking about what's going on. And sometimes as time goes on, things become more clear, and someone looking at things fresh but further down the road may have a different perspective. Certainly the Care Center Network, which is a group of centers across the country that will be expanding soon. Those are centers that, through the foundation, have access to educational materials. They take a multi-specialty approach to care, and I think would be a reasonable place to go for a second or third opinion, just to see, are there other things to think about for an individual patient that may not have been thought of, earlier on.
Yeah, thanks for that, Kevin.
Yeah, but I also want to just highlight that most of the care is in the community and is good care, and our talking here about getting a second and third opinion it should no way be implying that, if you don't do that, it means that you're getting substandard care.
Yeah, absolutely right. I think many pulmonologists, almost all pulmonologists have, or even all, have experience taking care of patients with interstitial lung disease. So I think in many cases it's not necessary. There are a couple of questions that have been typed in, and maybe we'll move to those for a couple of minutes. So one of them is, what's happening metabolically when my oxygen level drops below 85 to 88% for short periods, and how much danger of damage am I exposing myself to? I'll address that myself. Again, it's a little bit hard to tell for every individual person. It's hard to make general statements because the safe range of safe range of oxygen levels is probably different for different people. But generally, what we do as physicians is if we find that oxygen levels are routinely dropping below 88% in your blood, then we'll talk to you about using oxygen to keep those oxygen levels higher than 88%, because we think that might do some good. Certainly, there's some data that in the short-term setting, oxygen for some people can help treat or prevent breathlessness. And different physicians have different perspectives on this. We don't really have a lot of good data, so to speak, or well-performed studies on the long-term benefits of oxygen in pulmonary fibrosis. Regarding damage, I think that's hard to say. I mean, certainly, if you're dropping down below 88% for 10 seconds, it's very unlikely that's doing damage. But I always worry that repeatedly dropping down below that range over and over, multiple times a day, every day for weeks and months and years, you have to wonder how much damage that might be doing to some parts of your body, putting strain on the heart or other organs. But as I said, everyone's unique, and the kind of oxygen prescription really needs to be tailored to each individual person. We'll move to the next question, which was written in, which is, are there any...
Dave, if I could just add.
Kevin. Yeah.
I was just going to address this for a second. The other side of that as well is there's also not a reason to use too much oxygen and to try to use supplemental oxygen to put your saturations up to 99 or 100%. Because you worry a little bit about oxidative stress and damage as well. So there really is kind of staying in that normal range is important. And as you highlighted, you don't want to be low too often, but on the same token, there's not a need to use extra supplemental oxygen if you don't need it.
Yeah, exactly right. And for different people, their oxygen level goals will be different. There are some people where we really need to keep it in the low 90s for safety reasons. So again, it's something important to talk to your doctor about. So let's do another question that was written in, which is also about sarcoidosis. If pulmonary fibrosis comes along with sarcoidosis and the sarcoid is kept stable, does that mean that progression of pulmonary fibrosis will be slower? I guess meaning if we treat the sarcoidosis and it helps treat the sarcoid, will this slow down the progression of pulmonary fibrosis? I think the short answer is we don't really know the answer to that, and it probably also does vary from person to person. In general, a response to a treatment we think is a good thing, and there may be some short-term benefit to that, but the long-term benefit's really unknown, and that maybe ties into another very important point, which is that we really are terrible at predicting what's going to happen to people in terms of progression. Just as we talked earlier about these average survival rates, and as Kevin pointed out, that they're an estimate, that there's a wide range of variability around it. If we can't predict, we can't predict what's going to happen to you a year from now, 2 years from now, 3 years from now, regarding progression. At least I've been wrong many more times than I've been right about it. Kevin or Joyce, you want to share your thoughts on that regarding progression and treatment response?
I agree. I mean, I think that's one of the hardest things that we're asked to do as physicians, and I think that's one of the things that we do um, not very well. I think all of our estimates on natural history and prognosis and progression are really summary estimates based on populations, right? As opposed to looking at the individual patient and really looking at the entire patient and what would impact prognosis. And I think we just are not at a point where we can accurately do that for any of our interstitial lung diseases.
Yeah. Okay, great. So let's move on to the next question, which is what can I do to help with my cough? So that's let's see, Joyce, do you want to help with that? I find this probably one of the most challenging things to figure out clinically.
I agree. I think.
Oh, Joyce, I think you cut out for a moment there.
Cough. Hello?
Yeah, I hear you now.
Okay, sorry. I think cough is challenging because it's not just a manifestation of the underlying fibrosis. It can be due to other relevant conditions that the patient might have. For example, reflux disease or sinus disease can also contribute to the symptom of cough. So I think it becomes complex and difficult to treat because there may be multiple drivers for that single symptom of cough. And so, in my practice, we try to treat all potential contributors to that cough and see if that can improve symptoms. And many times we can lessen the cough, but we can't completely get rid of the cough. And certainly people are looking at novel ways to treat the cough, and people may be familiar with the thalidomide study in patients who have idiopathic pulmonary fibrosis. But it's a medication that's more challenging to get, and but it may help the cough in our patients who have cough predominantly related to the fibrosis.
Yeah, thanks for that, Joyce. I agree. Kevin, do you want to add anything?
No, I just second what your guys' comments have been. It's a very difficult symptom to try to control, and really just trying to see if there's aspects of it that we can try to address.
Yeah, and Joyce, I do exactly what you do. Is I try to treat a lot of the causes of cough that occur outside the lungs, and in many patients, I've found that helps quite a bit, although certainly not completely. And I agree, it's very important. Okay, so let's move more to some of the treatment questions. I think we actually addressed this one, being evaluated for lung transplant. I guess there's this, what are the most important things I need to know about lung transplantation? Is it covered by insurance? So I can try to address this a little bit. Boy, the most important things, and there's a lot of important things to know about transplant. And in fact, the first visit you make to a lung transplant center, often the doctor there and the nurse there will spend a good deal of time talking to you about lung transplantation, what it means, how to get on the waiting list, what life is like after a transplant. And many centers will also either encourage or perhaps require that you attend some educational sessions to get prepared for lung transplantation. Maybe the most important thing I can tell you about lung transplantation is how to get in the door and how to be a good candidate for transplantation. And by good candidate, what I mean is someone who is going to be fit enough for surgery. And fit, I literally mean physically fit enough for surgery. And it can be a pretty big surgery, as you can imagine, replacing one or both lungs. So I want to emphasize a couple of things about candidacy for transplant. So the first is that being active, participating in an exercise program like pulmonary rehab, and if indicated by your doctor, using oxygen can really help improve your candidacy for transplantation. Most transplant programs want to see that you're active every day, that you're able to participate in many of the daily activities that you'd like to participate in, that you're not necessarily confined to your home, Again, every transplant program is different and every individual person's medical situation is different, but trying to be active and participating in pulmonary rehab go a very, very long way. Another element that transplant programs consider is your weight. And some transplant programs have very strict criteria on the upper weight limit that they'll agree to put you on a waiting list. So if you are overweight, talk to your doctor about whether or not you need to lose weight in order to be considered for lung transplantation. The different programs have different criteria. Some are much more strict than others about body weight. So, but it is an important thing to talk about with your doctor. And there are many other elements. Transplant programs want to make sure that any other medical problems that you have are managed well, are under control. If your diabetes is out of control, they're going to worry about that. If you have kidney problems, they want to make sure that resolves before you get a transplant. So there are many elements here. I guess the other thing, maybe in some respects, one of the most important things, is to make sure that you're not alone. Transplant programs want to make sure that there are other people in your life who can help take care of you and manage what becomes a very complex condition after your transplant. Lung transplantation is not like getting your appendix out where a few weeks later, you'll never have to think about it again. After you get a lung transplant, we use the term lung transplant patient, even when you're healthy and well. So for the rest of your life, you're dealing with a chronic medical condition. It's not pulmonary fibrosis anymore, but it's being a lung transplant patient and taking all of these medications that can cause side effects and complications. So going through lung transplant alone is very challenging, and making sure that whether it's family or very close friends, very close friends that almost are family, transplant programs want to see that you have that support in your life. And then finally, the question here is about insurance. In general, lung transplantation, if indicated, ought to be covered by insurance. Everyone's individual case is different, and I apologize to sound like a broken record and say that over and over again. But it is true that every individual's insurance coverage situation is different, and even with the same insurance company, your policy may be different. And over time, out-of-pocket costs for everything, and I'm sure everyone on this webinar has experienced this, out-of-pocket costs for everything have gone up year by year. So even if it is covered by insurance, there may still be costs that you have to cover out of your pocket, meaning most things are not 100% covered by insurance. But don't let that stop you from looking into it, from talking to your doctors about it. And if you are referred for transplant, I encourage you to listen to your doctors and keep that appointment and learn as much as you can about transplantation, and try to do that as soon as possible. Don't wait for your disease to become very severe before you make your first visit to the transplant program. The process can take a long time, from the time you are referred to the program until the time you get your transplant. In some cases, could be up to 1 to 2 years. So getting in the door early can only help. Kevin, do you want to add anything there? Or Joyce?
No, I think those points were really spot on. Very good talking points.
Okay. Joyce, anything?
Agree with both of you.
Okay. Here, write in a question. When should psychotherapy be started after diagnosis? And Joyce, maybe I'll have you comment on this in one moment, but just to clarify, I think that we're talking about psychotherapy for people who not only have pulmonary fibrosis, but have developed depression or anxiety or another mental health condition, which we see quite a bit of. And Joyce, this probably is a question in response to you mentioning depression and anxiety before. And I'll just make the disclaimer that none of us are mental health professionals on this call. But Joyce, do you want to just briefly comment on that?
Yeah, I mean, I think I would talk to your pulmonologist and your primary care doctor about how you are coping with the diagnosis and the treatment, and discuss with them whether or not therapy beyond meeting with your pulmonologist, whether it's medical therapy or psychotherapy would be appropriate. I don't know that we can provide a one-size-fits-all kind of recommendation for that one.
Yeah, I agree with that. But it's also, as Joyce kind of alluded to, it's also the type of thing that you wouldn't want to put off if you're experiencing symptoms that you think might be related to depression. I think, as Joyce said, talking to your doctor right away about them and finding out the right management strategy is very important. And I've certainly seen many patients where getting counseling or psychotherapy can not only help manage their depression, but can help them manage their disease better. There's a lot of stress and anxiety and coping that happens with a medical problem like pulmonary fibrosis. So even in the absence of, say, a diagnosis of depression, psychotherapy or counseling can be very helpful for many people. I will say I've noticed that it can be very hard to access mental health services for anyone unless they have a ton of money they want to pay out of pocket to get mental health care. So I'd encourage you to talk to your primary care doctor, just as Joyce did, about the best way to access mental health care and psychotherapy. There's it's hard enough to see a doctor or a pulmonologist. It's I think even harder sometimes to get in to see a psychologist or a psychiatrist. But maybe that's a New York thing. I don't know. Joyce and Kevin, do you experience that in your neck of the woods?
It's tough. We rely heavily on
I
primary care doctors.
Mm-hmm. Kevin?
Yeah, this is Kevin. I would second that as well. It can be very difficult to get into specialty care, but certainly work very closely with primary care physicians. And just would highlight, what both of you guys have said about these are very common, but they're also things that I don't think we probably talk about enough, or certainly as much as, what did my breathing test look like and what's my oxygen saturation. So I would just echo what you had said, Joyce and Dave, that anxiety and depression are common symptoms, and if they're not being addressed or being asked about, don't be shy about bringing those up to try to get help for that, so that that can down the road have much better quality of life.
Yeah, I agree with both of you. Thank you. So we'll move on to another treatment question, which is about anti-fibrotic therapies. Are the anti-fibrotic therapies only stage appropriate, or is it, quote, sooner the better when it comes to starting these medications? Kevin, can I ask you to take that on?
Yes, I think it's, so if I break down the question, so I don't think that the anti-fibrotic are stage appropriate. The limited data that we have from breaking up the participants in the clinical trials into those that had more mild disease in the trial and those that had more severe disease in the trial, the effect of the drug seems to be the same across that. Now, it's true that not all stages of disease were in the trials, so we don't have data on all stages of disease, but my personal belief, and again, this is just my opinion, is that I think the therapies work across the spectrum of disease severity. When to start the medications, I think people have different opinions on, and it really factors in how people are feeling at the time, how the disease may or may not be progressing, what is your age, what other comorbidities, how tolerant might you be of side effects, also realizing that many people are on these medications and don't have significant side effects. So I think it's really when to start these medications is really a very, very, very important discussion that patients should have with their providers, with providers providing information, as opposed to having a one answer fits all type of response.
Thanks for that, Kevin. Joyce, anything to add?
No, I think that's absolutely true. I think it's a discussion with your doctor and balancing the side effects and the risks and benefits, and in the context of the patient and their other relevant medical problems and symptoms, I think is really important.
Yeah, I agree. I think you guys have addressed it, and I share your thoughts. We're going to talk about prednisone now. I am taking prednisone for my pulmonary fibrosis, and I'm having side effects, and I read that prednisone can be harmful. Should I keep taking my prednisone? So I'm going to say the answer is yes, and then I'm going to turn it over to Joyce to to talk about it in a little more detail. And I think we're laughing about this because this is something that comes up very often and can be very challenging in many ways, and is so different for each individual patient. So having said that, Joyce, what are your thoughts here?
Sure. So I think prednisone, yes, can be helpful for certain types of pulmonary fibrosis. And certainly the side effect profile of prednisone can make it very challenging to take. And I think maybe perhaps why Dave said you should keep taking your prednisone is that sudden discontinuation of the prednisone can be very dangerous. So if you have been on prednisone therapy for some time, you should remain on it until you can meet with your doctor to discuss the side effects and whether there are alternative medications or dose reduction that might be helpful in your particular circumstance. But you should never just suddenly stop taking prednisone because you could get very sick from that.
Yeah, I totally agree. And I think the harmful part of this is that there was a clinical trial that studied prednisone in combination with other medications, azathioprine and N-acetylcysteine, and people with people with idiopathic pulmonary fibrosis who were taking all three of those medications did more poorly than those who were taking placebo pills. But again, that's a very specific type of pulmonary fibrosis, and there are reasons for, as Joyce said, some people with pulmonary fibrosis to take prednisone. And in my practice, for example, I prescribe it to some of my patients as well with different forms of pulmonary fibrosis. So please don't stop it all of a sudden, as Joyce said, very important. Okay, so here's a different medication now. My doctor prescribed mycophenolate mofetil, but my insurance won't approve it. Do I have other options? I guess I'll take this one on. This is a tough one. Mycophenolate is a drug that weakens the immune system, much like prednisone does. Has a different set of side effects than prednisone, and very commonly is prescribed for people who have autoimmune conditions. I will say much of the use of mycophenolate in people with pulmonary fibrosis is off-label, meaning mycophenolate is not FDA approved to treat most of the forms of pulmonary fibrosis that we see, but that doesn't mean it's not appropriate. It very likely is appropriate and is widely used by many physicians to treat different forms of pulmonary fibrosis. There are, at least in my experience, I've been having difficulty getting insurance to approve this treatment for some of my patients. Let me ask you, Kevin and Joyce, just briefly, are you having similar problems?
Yes, I
Yes.
mean more and more for some reason, even in patients where we have traditionally not had too much difficulty, like our scleroderma patients with interstitial lung disease, we're seeing increasing resistance by insurance for coverage. I mean, technically, yes, off-label, but still becoming increasingly difficult.
Yeah. And Kevin, you're saying you as well?
Yep, I would second and third that.
Yeah. I mean, the scleroderma data is very good for well, not very good, but it's good for mycophenolate for people with scleroderma and pulmonary fibrosis. Yeah, it's very unfortunate. I in my own practice, use a lot of this, and we are having this problem. Other options would really depend on your own individual circumstance. I think certainly looking into whether or not there are other pharmacies or other patient assistance programs that might be able to get you some degree of coverage for it. You should certainly talk to your doctor about that. But then alternative medications, that really is not something I think that we could reasonably address here. There are other immunosuppressants, but the decision would really vary from patient to patient. So I'm gonna unfortunately, I'm just going to avoid answering that just because it's there's a lot of information packaged in there. So let's go on. We have a few more slides left. Has stem cell transplantation been effective for IPF? I'll address that one. The answer is not yet, or no. There have been a few small clinical trials that were rigorously conducted, very small. We haven't seen any. They were not designed to look for efficacy, meaning did it work? Did it help treat? And I will also caution you that the term stem cell transplantation has different meanings, and specifically stem cell transplant. And I should probably kind of back up some of my words here. The stem cell transplant is essentially a type of bone marrow transplant, which is used to treat certain blood cancers. So a stem cell transplant itself would not be appropriate just to treat idiopathic pulmonary fibrosis. But there are other types of stem cell therapies that are being studied, and I will refer people to a couple of sources about this. One is the FDA, which has put out statements about the potential for harm with certain stem cell therapies that are being offered around the country. You can find that on the FDA's website. And the Pulmonary Fibrosis Foundation has also put out a statement a couple of years ago that you can locate on our website at pulmonaryfibrosis.org that cautions people to think carefully and talk to their doctors about some of the stem cell therapies that are being offered around the country. But if the question is, has it been effective, the answer is no. And new clinical trials. Kevin, do you want to comment on this? You're involved in many clinical trials that are going on in the space, and it seems like it's an exciting time right now.
Yeah, I know we're kind of running close on time, but I think the exciting thing is that there are, multiple different types of clinical trials going on. Some of them looking at very old, simple, cheap therapies. Others looking at very new therapies that are very specific towards certain, fibrotic pathways. So, I think that the important message is that there are many novel therapies being looked at with pulmonary fibrosis. It's great that we have, with idiopathic pulmonary fibrosis, some approved therapies, but as we all know, we need to do better, and it's great to see that there's a lot of activity going on in that clinical trial space.
Yeah, and I think, this year, hopefully we're going to see some new trials move into the space. If you're not aware, there is a website called clinicaltrials.gov, that's .gov, where you can search for clinical trials that might be relevant to you. You can put in idiopathic pulmonary fibrosis or scleroderma and find clinical trials. In addition, that will often have the location that the trials are being conducted in, and hopefully a location near you. And we do encourage you to, if it's appropriate, talk to your doctor about whether or not there are clinical trials that you could enroll in. Again, I hope to see new clinical trials opening up over the course of the next year. And we have a couple minutes left. We have a write-in question, which is, please talk about the factors that doctors consider when deciding to go from medication to attempting to get on the transplant list. And I think that's a great question, because one thing that we need to reassure everyone and reinforce with everyone is that medical treatment, whether it's anti-fibrotic therapy or anti-fibrotic therapy, or whether it's immunosuppressive therapy, those treatments are often going on at the same time that people are being evaluated for a lung transplant. They don't need to be independent of each other. Your doctors may discuss with you changes to your treatments they want to make when you go on a waiting list, but certainly these things are often pursued and done at the same time. We're starting therapy at the same time we're referring you to the lung transplant program. So it's a comprehensive approach that I think most of us try to take. Joyce or Kevin, do you have any other thoughts on that?
No, I think I totally agree.
Yeah, I will say that let me just kind of step back to clinical trials for a moment. The PFF is very shortly going to be launching a search engine on our website to allow you to find clinical trials that are relevant to you, where you can put in your disease, your location, and get very detailed information about clinical trials. You'll be hearing more about that when we make the formal announcement soon, and encourage you all to explore that site. It may be very helpful for you. So that's the end of our webinar. I want to thank Joyce and Kevin for joining me today. I hope all of you got something out of this. I think we covered a lot of information and tried to do our best to give you the clearest and most accurate information. I also want to reinforce what I said at the very beginning, which is that you should not make any changes to your own medical care based on anything we said. You should talk to your doctor about anything you think is relevant to your health. I do want to announce our next webinar, which will be on lung transplantation in March. I hope you can all attend. We're going to talk about the pros and cons of transplantation, how you get there, and what to expect afterwards. So Joyce and Kevin, thank you again. I also want to thank Lori and Lindsay at the PFF for helping to make this happen, and to our sponsors, Boehringer Ingelheim and Genentech. So thank you all.